right, thank you so much. So my topic that I'm going to be discussing is imaging mandatory for left main artery stenting. These are my disclosures. So I'm going to get to the punchline. The answer is yes. I think it should absolutely be mandatory. But I'm going to go a step further, and I'm also going to say that I think it should be criminal if you perform left main coronary artery stenting and do not use intravascular imaging. And at the end of my talk, I hope you feel very similarly to the way I feel. So let's just talk about the anatomy of the left main coronary artery. So we know that it subtends most of the LV myocardium, greater than 75% of it. We also know that patients that have obstructive left main coronary artery disease have a particularly poor prognosis. We know that through natural history studies as well as through taking care of patients that have failed to undergo revasc. Now, one of the anatomic issues about the left main coronary artery is that it can be difficult to assess angiographically if the lesion that you see is actually significantly stenotic or not. Moreover, the atherosclerosis that you find in left main coronary artery is usually diffuse and very frequently involves the bifurcation, which has its own challenges. And then based on our last session, we know that calcific disease is also fairly common in the left main coronary artery as well, which obviously makes stent expansion problematic. Moreover, we know that the sequelae of hemodynamic issues, particularly when you have complications with left main coronary artery, PCI, and mitigating those is going to be paramount. So let's talk about the change in treatment effects and guideline recommendations in relation to medical advances. So if you look at the 1990s to the mid-2015s, what you see is that there's been some improvement in our ability to treat left main coronary artery disease through medications, be it through DAPT, be it through statins, etc. But it really hasn't caused a shift in the treatment effect that's fairly marketed. So if you look at the guideline recommendations, it's just barely above a class 3. If you look at CABG, it's been particularly great for a long period of time, from the 1990s to 2015, but there really hasn't been a lot of innovation. Probably the greatest benefit and change in surgical bypass has been the use of all arterial conduits, and I think that CABG remains the gold standard for the treatment of left main coronary artery disease. However, we as interventionalists have done a fairly good job in improving the quality of left main coronary interventions via a percutaneous approach. So from the 1990s all the way to 2015, what you see is that PCI has now gotten a 2A indication, where it may be appropriate. And a lot of it has really been driven by our pharmacology as well as stent devices, from bare metals to the first generation to the newest generation stents, as well as what I think is probably intravascular imaging. Now let's talk about the benefits of intravascular imaging. The first is that it firstly decides whether or not you actually need to revascularize. So we know from the LITRO study that a cutoff of 6 millimeters squared can be used to assess the need for a coronary intervention in the left main coronary artery. The second is we can also identify whether a one stent crossover technique is sufficient or whether a two stent technique may be more appropriate. Tomorrow I'll be giving a talk on the actual practicalities of left main stenting, one versus two stent strategies, so more to come. Moreover, you can appropriately size the stent, both from the diameter and the length, and then select the optimal landing zones. You can also optimize the final result. We know from the MLD Max algorithm that essentially intravascular imaging helps modify and help with that. And then lastly, clinical data seems to indicate improved heart outcomes, both as it pertains to death and MI, but also with TVF. And so I'm going to focus the rest of my conversation based on the last point, examining the data. So if you look at the risk-adjusted hazard ratios of clinical outcomes, particularly death, and you look at the three different waves in interventional cardiology. So wave one was from 1995 to 2002, and it was the bare metal stent era. If you look at wave two, that's the first generation DES, and if you look at wave three, it's the second generation DES from 2007 to 2013. And when you look at the comparison between PCI and medical therapy, so this is the totality of data regarding left main coronary artery stenting, and you look at PCI versus medical therapy for death, it's always been superior for PCI. If you look at CABG versus medical therapy for death, it's always been superior for CABG. And if you look at PCI versus CABG for death, there's actually clinical equipoise. When you look at MACE, however, what you notice is, let's just look at B, which is the CABG arm versus medical therapy. It's always been in favor of CABG. However, when you look at PCI versus medical therapy, it's only been in wave 3 that we've improved for MACE, where we are unequivocally better than medical therapy. And so if you look at the first 2 waves, there are no major differences. Now, the main reason that the MACE difference is not the same between CABG and with PCI is mainly driven by repeat revasc. So repeat revasc has always been superior for CABG versus PCI. But it's been in wave 3 where we've done a better job, where there is clinical equipoise when it comes to repeat revasc between PCI and medical therapy. And so the differences in outcomes have really been predicated on repeat revasc. So we have to do what we can to minimize the need for repeat revasc. And so what we have to understand is that when we're doing left main PCI, we're comparing ourselves to the surgeons. And so we have to get nearly surgical type outcomes. So let's talk about some of the clinical trials that have actually looked at angiography versus IVUS guidance for left main PCI. So this is one of the first trials which was published by Park et al. In 2009. It randomized patients. It was 145 matched pairs receiving drug-eluting stents, and the 3-year incidence of mortality was lower in the IVUS-guided arm compared to the angiographic arm for left main interventions. And there was nearly a 4-fold lowering in the mortality if you used IVUS compared to if you did not. There have been subsequently many other analyses and clinical trials, but this meta-analysis, which goes out to 2017 and looks at all-cause death, shows that if you use intravascular imaging with IVUS compared to angiography, that the totality of data really shows that you can decrease mortality with IVUS. Since that meta-analysis, we also have the ULTIMATE trial. And the ULTIMATE trial actually included patients with left main coronary artery disease. Unlike a lot of randomized IVUS trials, which excluded left main, this trial allowed for left main. And basically, again, we know that the endpoint, target vessel failure, is lower in the IVUS guidance group compared to the angiography group. And earlier this year, the Rolex registry was actually presented at EuroPCR. And this trial took 450 patients with unprotected left main disease that had intermediate or low syntax scores and were thought by the heart team to be appropriate for left main coronary artery stenting, and looked at PCI with Resolute Onyx. And the reason for this was basically to assess the safety and efficacy of the latest generation of the Resolute Onyx for left main coronary interventions. But what's notable is just a touch under half of the patients underwent intravascular imaging. The vast majority with IVUS, but OCT was also utilized. And when you looked at the primary endpoint, which was target lesion failure, it was about 5.1%, okay? And that's for all comers. But if you look at the sub-analysis that looked at intravascular imaging and you looked at angio-guided PCI versus IVUS and OCT-guided PCI, what they found essentially was that there was an even greater lowering in the endpoint if you used IVUS or OCT compared to angiography alone. Moreover, what they found is that when you used IVUS and OCT, half of the time it led to a larger stent platform, so that you started to use the 4.5 or the 5.0 stent as opposed to the lower size stent. And then as a result, in those patients, there was a halving of the primary endpoint. So the conclusion is, when you use intravascular imaging, you use bigger stents. When you use bigger stents and you have a better area, it leads to superior outcomes. Now, there's an ongoing clinical trial, the Optimal trial. Adrian Banning and Luca Testa are the PIs for this trial. And this is an ongoing trial out of Europe that essentially will have 800 patients with de novo unprotected left main or osteal LAD and Stirk disease. And they'll be randomized in a 1-to-1 fashion to angiography alone versus IVUS-guided approach, the composite of all-cause death, stroke, MI, and repeat revasc at 2 years. So this is ongoing, and this should be the conclusive trial for us. And for those that are interested, I mean, Gary, as we know, has been fairly prolific in this space, but he specifically was the primary author of a consensus statement from the European Bifurcation Club looking at IVUS in the treatment of left main coronary artery disease. And more recently, we now have a new journal as part of the JACC family, JACC Asia. And there's a state-of-the-art paper on left main coronary intervention, specifically with a focus on IVUS as well. So I'm going to conclude here. The main conclusions are: one, we know that left main coronary artery disease is one of the highest risk coronary artery subsets. Two, intravascular imaging has the ability to decrease MACE and TVF rates with PCI as much as 50% that we know. It stands to reason that intravascular imaging should be regularly utilized to decrease MACE and TVF rates in one of the highest risk PCI subsets. And then four, we know that recent clinical trials support this notion and a large RCT is underway. Thank you so much.